Dr. William Cromwell brings over 30 years of expertise to lipidology, currently leading research and medical efforts at Velocity Clinical Research, and, importantly, Chief Medical Officer at Precision Health Reports. Please welcome Dr. William Cromwell.
Well, good morning. I got in at 1:30 this morning. I didn't know it rained in Las Vegas. It evidently rains a lot in Las Vegas. That caused the rolling delays, so with my 4 hours of sleep, I am pseudo-awake. That's all right. A couple of thoughts about this talk. This is not the usual conversation that I have with people. It's going to be mortality focused. But to have that conversation, we need to set some context. And so that's what I'm going to do. I have disclosures. That's them. I'm happy to keep them up there for a while. Some speakers just go bam, bam, and you can never even read them, right? So I've done a few things with a few people, right? Where are we going with this conversation? I think it's really important to begin by having an understanding of the challenges that we have encountered in understanding the development of disease outcomes, which can be non-mortality outcomes as well as mortality outcomes, and kind of ask the question, where are we today? It would not surprise you that this is controversial. It would not surprise you there are differences of opinion. That's okay. We're going to embrace that. What we'd like to understand also is the degree to which metabolic and inflammatory issues contribute to mortality. And these are learnings that have come to us piecemeal in various disease states. My research group has contributed to this over the past few years as well. But I think what you'll understand is that there is a relationship which underpins people's likelihood of dying of various things. And this being a metabolically centric audience, I think you would appreciate the fact that it's not all about one biomarker, yet it is about our physiology and ways in which our physiology can set us up for success or failure. And that's basically going to be the way that we kind of pull this thread through toward the end. So I have a couple of introductory slides that are purposely intense. This is one of them, so do not glaze over. It's all right. I'm taking a 45-minute section of time and giving you about 45 hours of ideas, but I can't do a deep dive in all of them. But I started in this field 34 years ago. I started my first lipid clinic in 1988, 89, at which point nobody cared, right? And over the past 70 years, we have been informed by genetic data, observational data, intervention trials, a variety of things. And just to let you know, where did lipidology begin? Lipidology began in the 1950s by the work of Goffman and Lindgren. You see, these guys were the ones who characterized the fact that cholesterol didn't just float around in your blood, they were carried actively by lipoprotein particles as represented in this little cine loop. And these particles can be atherogenic, punitive, or they can be protective. The punitive particles, for various reasons, can make their way into the wall of the artery where they can be part of a process of atherosclerosis. And so we went from there to the standpoint of understanding that there were issues that helped us develop a plaque, progress a plaque, and contributed to outcomes. So if you look at plaque formation, in general terms, we have modifiable risk factors that can increase or decrease your risk, and actually it can go back and forth. It's not monolithic, it's not set in stone. These factors are very dynamic, and if you notice in the yellow, these will impact risk variably over time. You also have non-modifiable factors, age, gender, etc. And from plaque formation, we have plaque progression, which is generally influenced in a similar fashion by modifiable and non-modifiable factors. And this goes on to atherosclerotic cardiovascular events, ASCVD events, which can be fatal or non-fatal. But more recently, we've imposed on the top of this little diagram the fact that you can have interaction between modifiable and non-modifiable factors. You can also have genetic factors, environmental factors, diet, lifestyle factors, comorbidities, which can augment or attenuate your risk, and that can go back and forth, and they can influence both the other non-modifiable and modifiable factors. Now, if that looks very busy, it is, and that's you every moment of your day. Can you understand why it would be very difficult to tease out of that the relationship of one biomarker as being the only point of reference that is important? And this is where I think you will hear me say throughout this talk, it is more complex. It is an interaction of many variables. And what makes us individual needs to have something of this in the conversation. So we have conflicting data. And you can ask a simple question, what really matters? My statement is that conflicting data have sparked a lot of debate regarding what biomarkers you should care about, what comorbid conditions you should care about. Are therapies absolutely necessary? Do we need things like LDL lowering drugs? And if so, what is their potential benefit? Another way to say this is there's a parable of the 6 blind men and the elephant. You remember that parable? They have an ability to detect a certain amount of information in their environment, but it's limited because they're blind. And as they feel around the elephant, they're reacting to the data they see in front of them. It's a fan, it's a wall, it's a rope, it's a tree, it's a snake, it's a spear. Well, we do the same thing, right? LDL cholesterol significantly predictive of atherosclerotic cardiovascular disease. Or not. Atherogenic lipoproteins, not lipids, are what are causal for atherosclerotic cardiovascular disease. ApoB is causal but insufficient to try to understand the relationship with ASCVD risk. Causal risk factors that predict non-fatal events should predict mortality. Mortality actually depends on factors independent of causal risk factors. And I'll tell you that depending on the analysis, all of these conflicting opinions can be simultaneously correct. And that's the truth. Now the problem is, if we have an investment in one of these, we can become very attached to our worldview. And we become very attached to our worldview, we are defending a worldview despite other data. So how do we move forward? One of my favorite quotes to try to embody what I just said is from Mark Twain. It ain't what you don't know that gets you into trouble. It's what you know for sure that just ain't so. So I think that's where we're at. It's what you know for sure that just ain't so. And I hope I'm one of those guys who will be a lifelong learner, who would be able to look at conflicting data in a constructive way. Another way to say that is I've called this meeting today to kick around some ideas on how we might get out of these cages. All right? We're not doing anybody any favors by retreating to our camp and saying, I told you, and we fill in the blank. Or you have conflicting data and say, but that's usually not the first answer to trying to integrate anything. So with that in mind, there are factors that contribute to our conflicting data. And this is a nerdy slide, and for those of you who are kind of scientifically oriented in the room, the latter part of the slide will make more sense. But the questions you ask and the way that you handle data determine your observations. Ask a bad question, get a bad answer. Ask the wrong question, get the wrong answer. Ask the right question, you're getting data that you might be able to deal with. Multiple observations can be true simultaneously. Individual observations often reflect aspects of the same entity. In many cases, conflicting observations are the result of inconsistent data analysis and how much adjustment has been made for interrelated variables. I live in that space. For 30 plus years, I have been involved in basic science and clinical research. I've done a fair amount of publishing. My group as a whole, nearly 700 peer-reviewed papers. We've learned a few things. I will tell you how you handle the data matter, and two people can handle the same data 2 different ways and have 2 different conclusions. There are confounder variable effects replete throughout this disease. It is what it is, and you have to deal with them. Analytic discordance between alternate measures of punitive biomarkers. LDL is not cholesterol. Cholesterol does not cause vascular disease. There is no good or bad cholesterol. There are particles that carry cholesterol that can be punitive or protective. How you quantify particles that carry cholesterol can be done directly by some measure of particle number or indirectly by the cargo they carry. The cargo they carry and the number of particles present can agree, be concordant, or they can disagree, they can be discordant. When they disagree, risk tracks with particle number, never cholesterol, period, end of comment. Cholesterol never gets it right unless it agrees with particle number, period, end of comment. These are things you can write on a rock. There is no exception to those rules. Contrasting observations using new analytic techniques can cause us challenges. That's true in the imaging world especially. Variations in trial design, execution, and duration. All clinical trials are not done the same way. Observations are time-dependent, population-dependent, and execution-dependent. Therefore, you would have a very hard time reconciling things. And risk factor interactions that augment or attenuate risk can occur differently at different stages of the disease. Things that drive plaque formation are not necessarily the things that drive events. Things that drive plaque progression may be different than the things that initiate plaque. So the fact that these things exist in a dynamic state is also true. So here are some basic principles for resolving conflicting observations. This is Bill's rules for how to be a nice guy in this space. All right? Number one, we're on a journey, we're still learning, we haven't arrived yet. Number two, treat all data as informative. Number three, seek to understand why data conflict. Number four, drivers of disease progression, outcomes, including all-cause mortality, are complex and significantly influenced by various factors. You cannot exist in a vacuum. Punitive risk factors differentially influence that. Significant individual heterogeneity exists within a group. A group of high-risk people are not monolithic. Just because you carry a high-risk label doesn't mean everybody has the same risk. New analyses bring new understandings. Models of disease need to be adjusted to accommodate new learnings. Sometimes our model of disease is not adequate to accept new information. We have to modify the disease model. And finally, remember that there is a patient at the end of the exercise. I will come back to that many times. One of my strong biases is that we want to do the right thing one patient at a time. And if you're going to do that, you're going to have to open the aperture and see a little bit more than just what's straight in front of you. So from that, we're going to talk about current challenges in mortality risk. In general, the best case scenario is you're healthy, you get old, and you die. Not so bad. The not so healthy is you get things. And if you have things, you die anyway. But, if you're interested in why that might happen, what factors drive mortality, we kind of worked our way backwards. We say, well, we'd like to understand the disease in the first place, so we have the risk factor model. There are risk factors that put you at risk for developing these things. Maybe it's those risk factors that put you at risk of death. Seems logical, but not necessarily consistent with all data. So if that's the case, are we missing a common predisposing mortality set of factors, which are really setting you up for failure, independent of the risk factors that I'm showing you here? And indeed, metabolic malnutrition and inflammatory syndromes are a common soil out of which mortality grows. And specifically, we're going to talk about that for the rest of this talk. So this idea that metabolic and inflammatory contributions to mortality exist go back to some well-trod ground where there's an intertwining of malnutrition and inflammation in several populations. We see this in older folks. We see this in various chronic diseases that are characterized by cachexia, malnutrition, and frailty, such as chronic kidney disease, liver disease, congestive heart failure, chronic obstructive pulmonary disease, rheumatoid arthritis, cancer. These folks age differently. And as their disease gets worse, it's common for them to become thinner. It's common for them to have other metabolic issues which are inherent to these disease processes. So syndromes of coexistent malnutrition and inflammation go by different terms, different names. You've seen them here: protein energy wasting, cachexia, sarcopenia. The one I like is malnutrition inflammatory complex syndrome. It's a syndrome. Studies are hampered because we have imperfect clinical assessment tools to determine the presence of this complex, intertwined malnutrition inflammatory syndrome. And the main markers of this, if you look at the literature, things like albumin, C-reactive protein, are pretty blunt instruments. So if we look at the inflammatory malnutrition syndrome, I'm going to build this slide from the center out. This is for people with chronic kidney disease. You notice that in the center, the end result of many inputs that you'll see is some type of malnutrition, some type of inflammation, and this Venn diagram shows this overlapping characteristic. The inputs are many and varied. They can range from nutritional loss, the actual dialysis itself, various endocrine disorders, comorbidities, lots of inputs. And the outputs are biochemical outputs, compositional outputs, various survival paradoxes, which I think are very curious, right? We think of obesity as an indicator of insulin resistance metabolic syndrome, but it's the obese people who don't die as much. It's the lean people who do. It's the people with the low blood pressure who are dying more. It's the people with the low cholesterol who are dying more. And is that a reflection of this underlying pathophysiology? Or are these punitive risk factors not as related to the disease as we once thought? Well, the authors highlighted the fact that no single biomarker can adequately address the features of this metabolic inflammatory syndrome. Instead, you need multi-markers. And a multi-marker is a combination of markers which better perform than single elements thereof, and we'll talk about that. So the populations with a high prevalence of this malnutrition inflammatory complex have this paradoxic relationship that I just said about. It's low BMI, which is problematic. It is low cholesterol, which is problematic. It is low blood pressure, which is problematic. And you can see and have seen many talks where they have a J-shaped or U-shaped curve. Now, in your mind's eye, just think on the bottom, you're looking at something like BMI. And BMI is low on the left and it's high on the right. And on the y-axis is mortality. So as you start with a high BMI, your mortality risk appears relatively high, and it goes down as you get to a more normal BMI, but then as your BMI goes below a certain point, the mortality risk goes back up. Same thing can be true with blood pressure or cholesterol. And we have to somehow deal with that. So is this relevant to cardiovascular disease or individuals at low risk? That's an open question. I just made the case that we see this commonly in variously diseased individuals. But is that true for cardiovascular disease or people at low risk? Well, this is where our group tried to make a contribution to the literature with a multi-marker called MVX, Metabolic Vulnerability Index. So what you see is that Jim Ontvos and I have worked together for nearly 3 decades. He is credited with the application of nuclear magnetic resonance spectroscopy for quantifying various biomarkers, lipoproteins, chief among them, but also inflammatory biomarkers, other nutritional biomarkers, amino acids, ketone bodies, a variety of things. And because NMR is a platform where there's a lot of information deeply embedded in it, you can extract from that individual things that you can then take back to certain study questions and populations and ask the question, what have we learned about metabolic inflammation and what biomarkers could give us better visibility to that? And what we found was that there were 6 biomarkers, 2 of them of inflammatory origin, 4 of them of metabolic origin, that gave a good indication of whether we had an inflammatory vulnerability or a metabolic vulnerability underlying the various populations that we were interested in. So we aggregated this into a multi-marker called MVX, and MVX is made up of glyc a systemic inflammatory biomarker which has attributes which are much superior to hsCRP, small HDL particle number, which has a very strong association with not only inflammation, but a variety of other physiologic functions, leucine, valine, isoleucine, citrate, metabolic markers of metabolic health. And when we combine these into a multi-marker with a score that ranges from 1 to 100, we can then take this to populations and ask some questions. One of the populations we looked at early on was called CathGen, and I'll tell you about CathGen in just a moment. It's a repository at Duke University of individuals who came in for a cardiac cath. They acquired lots of information, and they said, well, good news is you're not dead yet. We're going to follow you for a while, and we're going to see what we can learn. No worries, we're just going to be like little birds on a fence watching you do. And if you die, we're going to say, woo, what did we just learn? A lot of people do this. Intermountain Heart, they have another one, biorepository. We're going to watch you do. We also have observational studies, things like MESA, the multi-ethnic study of atherosclerosis, a tremendously important population because MESA is like a modern-day Framingham heart study. And as you heard from Matt Budoff yesterday, Matt has been a principal investigator and lead in MESA. I'm a principal investigator in MESA as well. Prevent, Cardia are other populations that we have looked at. So the idea would be, with access to these populations and what we already know from them, would MVX teach us something new? Well, let's find out. So this is one of the articles that we published in Lancet fairly recently, 2023, asking the question, what does MVX do as a marker of mortality in this well-characterized population? The objective was to assess 5-year mortality using MVX and CathGen, and then to proof test that against a second cohort, Intermountain Heart, and these are both biorepositories. The subjects were 18 years of age or older. In CathGen, they were enrolled between January 2001 and December 2011. Intermountain Heart, September 2000 to September 2006. They all underwent cardiac catheterization, and they had biomarkers available for us to interrogate as we watched them either live or die. And I told you about what MVX is already, and we're looking at the mortality associations, and we're comparing them to covariance. Now remember, there are other reasons that people could be at risk of death. Being old is chief among them. Who knew old people die? So that becomes a real sticky wicket. If you're thinking that something else can help you understand mortality, you have to adjust for age. And usually when you adjust for age, other things kind of fall by the wayside pretty quickly because age is that factor which kind of trumps many things. So you're going to see this impossible to read slide build for you. Oh joy, I've got several of these. Sorry about that. So we're going to just pull out the top, and I'm going to characterize a couple of things for you. Number one, we're talking about an individual population of 5,876 folks, 1,000 of whom died. That's a pretty good sample size. And in the case of Intermountain Heart, we're talking about a group of 2,888, of which 441 died. And it would not surprise you, as I show you here, that people who are in the dead group are older than the people who are in the not dead group. Okay. It's always good to see things that you expect, right? It would be odd not to see that, so I'm good with that. We can also look at a few other things. We can say that diabetes, if you look at this, if we're looking at percent, the people who were dead, higher percentage of diabetes, okay, that makes sense. We can also look at BMI. So here's BMI, and people who are dead, a little bit lower BMI. All right, that's interesting. What about these chronic conditions, heart failure, chronic kidney disease, previous heart attack, coronary artery disease on angiography, comparing the dead group to the not dead group, relatively greater frequency. Okay, that makes sense. Got that? Well, what about their biomarkers? I did take the liberty of converting millimoles to milligram per deciliter because we are in the US. So you might or might not know immediately what a 3 millimole cholesterol value is. I just thought I'd put that in there. So what does this teach us, interestingly enough? Well, if you take a look at it, total cholesterol lower in the dead group, HDL cholesterol lower in the dead group. All right, that's interesting. Inflammatory Vulnerability Index, that's glyca and small HDL particle number, higher. Metabolic Vulnerability Index, those are the 4 biomarkers of inflammation, higher. MVX, the aggregate score, higher. All right, so we're seeing some trends there, interesting. Now, the next 3 slides could be mind-numbing. I hope they aren't. I'm going to tell the story, and then I'm going to let the slide build to reinforce the story. The story is that there are drivers of outcomes which are not fatal, and there are drivers of outcomes that are fatal. And I said early in my talk that perhaps the drivers of non-fatal outcomes could be different than the drivers of fatal outcomes. Well, is that the case? Well, if we just take a look here, notice that as far as age is concerned, there is a strong signal here for age in the mortality group, but not in the non-fatal group. That's interesting. Over here, you'll see that smoking, hypertension, diabetes, heart failure, family history, unique to the fatal group, not the non-fatal group. But prior MI and angiographic coronary disease, significant for the non-fatal group, but not the fatal group. All right, well, that's interesting. And then down on the bottom, you'll see a little bit difference in BMI. BMI, a significant individual univariate for the fatal group, but not for the non-fatal group. So you're going to see this kind of play out, differences between the two groups. Now, what we do is begin to introduce elements of MVX. Remember, MVX is a multi-marker that consists of 6 entities. I can put the individual entities here. We'll do that on this slide. The next slide, we're going to begin to aggregate them into the IMX, the inflammatory vulnerability score, and MMX, the metabolic vulnerability score. So when we do this, what do we see? We see that these biomarkers, absent leucine, significant individually for mortality risk, and to some degree similar for non-mortality risk. Now, when we look at the degree to which these others are contributing, once again, race as just a univariate, significant on one side versus the other, family history, MI, or MICAD, non-fatal side, BMI, fatal side, HDL cholesterol, non-fatal side, estimated glomerular filtration rate. See, so there are differences. Kind of interesting. What happens when we're now with the composite? We see that in this case, there are their relationships, and once again, the red boxes on the right are different than the red boxes on the left. This does not get a lot of attention, but it reinforces the fact that different risk factors, comorbidities, and biomarkers have differential associations with fatal versus non-fatal outcomes. It is what it is. All right, and now the big drum roll. These two terms, IVX and MVX, interact. Interaction means that at the same high tertile for IVX, there is increased mortality association as a function of MVX, and vice versa, at the highest tertile of MVX, there is a graded association as a function of IVX. So instead of just adding two terms together, you would be better served to allow the data to predict a multi-marker term that would allow for interaction, and that is the multi-marker term. If you were asking, well, what is the gender-specific MVX equation? It's that. Just thought I would show my work. It's always good to show your work, right? So, show your work. All right, I'm showing my work. Thank you. Yeah, always good. You know, if you're wrong, it could be because your work's wrong. That's okay, too. You should be very transparent. So here is MVX, and this is going to tell you a couple of stories. Number one is MVX, and these numbers we haven't focused on. I was telling a story with red boxes before. Now I'm going to switch and tell a story with actual numbers. What you're looking at in this category box here is called chi-square percent. What on earth is that? Chi-square is a statistical metric of the degree to which a biomarker is strongly or not strongly related to the outcome of interest. There is a total chi-square, and then you can say what percent of the total is the individual biomarker. So percent chi-square is, of all of the outcome association observed, what percent is due to MVX? 69%. That's a pretty strong number. What about age? 17%. The next slide, I'm going to have these numbers highlighted in a different way. And what you're going to see in the next slide is if I never had MVX in any way available to me, age would be a very dominant percent of the total risk. But as I incorporate MVX, age begins to drop quite a bit. All right? So here we have these factors, and once again, sorry, hit the right button. The red boxes on the right are different than the red boxes on the left. So what we have done progressively over the past several slides is we have gone from an unadjusted analysis where we're just looking at the common things. We've introduced elements of metabolic and inflammatory vulnerability. We have rolled them up into a weighted average gender-specific multi-marker, and now we're seeing that there is still a consistent story as we do that. The red boxes on the right are different than the red boxes on the left, but the rest of the story. Anybody remember Paul Harvey? I love Paul Harvey. Shows you how old we all are, right? So now the rest of the story. So here is what it looks like in a bar graph fashion. So this is the relative contribution to mortality risk using the 15 covariants, just the usual stuff, and 28% of the risk is due to age. Now, when I add in the individual elements of MVX, this goes down to 22%. When I aggregate into IVX and MVX, it goes down to 21%. And if I look at MVX as a gender-specific weighted multi-marker, it accounts for 69% of the mortality risk, and age is down to 17%. What this is teaching me in this cohort is that you can be set up for disaster. You can be a metabolically vulnerable individual, and independent of your age, you've got one foot on the banana peel. This is not an atypical story. I often ask my colleagues an infectious disease question. Why does one patient die and the other not? Same age, same infection, same organism, same tissue site, same antibiotic. One lives, one dies. And the old school answer is, well, one was a better host and the other was a more compromised host. It was something about the host. Because in this analogy, an antibiotic is like a club. I give you a club, you go beat up the organism. What if you're too weak to hold the club? The club is still there, but you can't wield it. So this idea that you have a compromised host shows up in certain disease states. Well, what if the idea of a compromised host is true regardless of disease state? What if being compromised puts you at risk of death due to atherosclerotic cardiovascular disease, cancer, COPD, chronic kidney disease, congestive heart failure? Well, that would be something. Indeed, that's what you're going to see as we go along. The next way you could ask this, and this is probably the most chilling slide in this deck, is there a relationship between the magnitude of MVX and your likelihood of dying over 5 years in cath-gen? Indeed. Which curve are you on? If you're on this curve, your mortality risk is very high. If you're on this curve, it's very low. And if you'll notice, age is not markedly different over many of these. That's interesting. This is the quintile view of that in cath-gen. This is the quintile view of this in Intermountain Heart. They confirm one another. All right, is this a story which is true in meaningful subsets of patients? For example, men versus women. The increment of risk due to a 1 standard deviation change of MVX is shown here. This is the top versus bottom quintile. So indeed, MVX risk is equal for men and women. It is true regardless of your age, less than 50 or over 70. It is true regardless of your BMI, less than 22 or over 30. It is true whether you have or don't have hypertension, whether you smoke or whether you don't, whether you're diabetic or not, whether you have heart failure or not, whether you have a previous MI or not, if you have angiographic cardiovascular disease or not, chronic kidney disease or not, or whether you're just healthy. Wow. This is common soil that transcends disease states. This might be an interesting new learning. So, what about a healthy population? The multi-ethnic study of atherosclerosis, MESA. Average age in the early 60s, free of disease, followed longitudinally. What would the quintile MVX association with mortality look like in men and women in MESA? The same as you saw with cath-gen or Intermountain Heart. I could show you this for PREVEND. I could show you this for other populations as well. This is taken directly from the paper, and it is implications. What are the implications of this? Our results suggest that survival might be more dependent on previously unrecognized causal factors distinct from those that are responsible for the development of disease. Treating the underlying metabolic dysfunction of these overlapping syndromes might provide greater survival benefit than targeting conventional disease risk factors. Okay, now we just threw a hand grenade in the room. I'm all about treating modifiable risk factors. I have no idea if that will extend your life one day. But all is not lost, because what I can say is I can significantly improve your likelihood for heart attack, stroke, and lifestyle-related or life or health span-related issues. I have this conversation with my patients. What does a great day look like for you in your mind 10 years from now? Hold that thought. Are you more likely to have that great day if you've had a heart attack or a stroke or not? So we can do things that start with diet, exercise, comorbidity management, risk factor modification, and give you a better chance of avoiding some of these heart attacks and strokes, but I have no idea if it's going to extend your life one day. That is more likely due to metabolic vulnerability than risk factors. This is where data teach us. This is where we open the aperture. This is where we allow the disease model to grow. This is where multiple points of view can be right simultaneously. And I'm okay with that. And I hope you guys are too. So let's apply MVX to heart failure. This is a more recent paper in 2024 asking some of the same questions in a heart failure cohort. This cohort is looking at MVX and its relationship to mortality and heart failure. 1,382 subjects. This is the Rochester Epidemiologic Project, another biorepository, using the same things. MAGIC is a score which looks at various biomarkers that are unique to heart failure mortality. NT-proBNP is a biomarker of CHF risk. Again, we have one of these tables with lots of different things. You saw that before. I'm going, for the interest of time, move on. This is the distribution of MVX in this population, relatively symmetric. This is the relationship of MVX with mortality. This cubic spine shows the 95% confidence intervals in the actual data, which means the data across a continuous fashion falls within the 95% confidence intervals, and it has a very graded relationship. So we're seeing a similar story with heart failure. These are the individual survival curves. So going down is bad. You're surviving less. This is an MVX which is not as bad. This is an MVX which is worse. If you look down here, you see the actual numbers. So the higher the MVX, the more the mortality as a function of time. The key findings were that MVX was associated with a large increase in risk of death in those individuals who had a spectrum of heart failure, significantly graded and positive. The highest MVX group was 3 times more likely to die compared to the lowest MVX group. MVX remained significant after adjusting for the typical confounders like MAGIC score, ejection fraction, and other biomarkers. And the results were consistent with the heart failure cohort of CathGen. Now, we're going to tack into something a little different. We're going to look at a different biorepository from China. And they're asking a different question. What's the relationship with ApoB and mortality? That's a loaded question. By the way, I'm an ApoB guy. But I don't believe ApoB tells us everything. I believe ApoB is part of the causal pathway of vascular disease. I believe lowering ApoB decreases progression of plaque. I believe lowering ApoB is associated with fewer non-fatal events. And in some data sets, lowering ApoB may be associated with a reduction in fatal events, but not all. So in this cohort, you have assessment of baseline ApoB with mortality. Interesting. 36,000 individuals in this registry that came in for a heart cath. Sounds very much like CathGen. They segregated them into those who had an ApoB above 65 or below 65. Now, they call those high and low. 65 is low, and being above 65 is not high. But they call it that. That's fine. And they're looking at the association with risk. So just to point out a couple of things, here we're looking at people who had higher versus lower ApoB, and you see some of the characteristics here with respect to heart failure, hypertension, chronic kidney disease, malnutrition. They were looking at nutrition, and they asked the question, how many people had no evidence of malnutrition? In those who had low versus high relative ApoB, those who were metabolically healthier had a high ApoB. Those who were not as metabolically healthy had a lower ApoB. And then they broke it down by the degree of metabolic stress, if you will, or malnutrition. And notice the all-cause mortality was higher in those with lower ApoB than those with higher ApoB. So what I'm going to show you now is a series of plots. This is the unadjusted plot in 38,000 individuals of ApoB on the x-axis and mortality on the y-axis. And as I look at this, it appears that the lower the ApoB, the greater the mortality. Interesting. What about if I adjust this for age, gender, and comorbidities? The curve is slightly different, but it's still doing this. What have we learned in this talk? That there could be an association between metabolic vulnerability, inflammation, and mortality. This publication is looking at malnutrition, metabolic vulnerability, as a disease state. And look at this. If I adjust for nutrition, that line straightens out, and there is a relatively linear relationship with decreased mortality and lower ApoB. But before, that's not what I saw. But if I adjust for metabolic vulnerability, that's what I see. Multiple observations can be true simultaneously. It matters how you handle the data. We have to open the aperture. We have to adjust for confounding factors. We can learn things. Multiple points of view can simultaneously be correct. So new learnings in mortality outcomes. Mortality outcomes are driven by different factors than those that are responsible for disease development, progression, or non-fatal events. That is true. In the elderly and chronically ill individuals, there's a well-documented link between mortality syndromes and the combination of metabolic and inflammatory vulnerability. The paradoxic relationship is on full display with increased BMI, blood pressure, and cholesterol being associated with decreased cardiovascular and all-cause mortality in those populations. But when you adjust for metabolic vulnerability, you get different results. MVX significantly segregates risk independent of age and across a variety of disease states. So let's put this all together and land the plane with 2 minutes and 50 seconds left. So yes, I will stay within time. I understand Dave's been pretty hard on that. So I don't want to get hooked off the stage, right? Drivers of disease progression and outcomes are complex and significantly influenced by various factors. What do the guidelines say we should be doing right now? The guidelines say that individual risk should be assessed by beginning with a calculated risk based on usual factors, but we don't end there. We consider comorbidities and over 30 risk-enhancing factors to further understand individual risk. We integrate biometrics and outcome-proven biomarkers to further inform risk. For example, what's up with your vessels? Do you have subclinical disease? That's a different conversation. We harmonize U.S. and international guidelines to define individual risk and opportunities, and very importantly, this comprehensive assessment is married with patient outcome goals. What's important to the patient? Is having fewer heart attacks or strokes okay if it doesn't make you live a day longer? And if that's okay, we ought to do that. And we should not misrepresent to people that if you don't live a day longer, it doesn't matter. It does. At the end of the exercise, there's a patient, and we should be committed to excellence. I'm going to tell a story briefly that I don't commonly tell, but it's true, so you can know a little bit about the guy who's talking to you. I started my practice in 1989 in lipidology. One of my first FH patients was a lady named Sue. I moved my practice to Florida in 1994. In 1995, I came back from vacation. My phone was ringing. I answered it when I got in the house. It was Sue's son, who called me to tell me that she had died. What happened? When I left her, she was in good shape. She had had a heart attack. She had a heart cath. She had multiple small blockages that they shouldn't worry about. During her hospitalization, one of these small blockages gave her another event, and she died. I expressed my condolences, and 24 hours later, I was at his house. And for a week, I stayed with that family. And during that week, questions were asked. Did this have to happen? I didn't think did. So during that trip, I made a commitment. And the commitment I made was that I would do the things I could do so there would be fewer Sue stories in the world. And this is my commitment. Excellence is a result of caring more than others think is wise, risking more than others think is safe, dreaming more than others think is practical, and expecting more than others think is possible. Do the right thing, one patient at a time. If you're going to do that, you're going to have to open your aperture. You're going to have to know that we risk being very defensive about our worldview and not very inclusive of new learnings. I hope I'm a lifelong learner. I hope this community, which is very invested in science and moving the needle forward, will have an increasing voice. That's why I'm here, because I want to be a part of the shared voice in this space. We still have a lot to learn. But the way we ask questions and the way we handle data have a lot to do with what our opinions are. And with that, I will yield back my time to Dave, and thank you very much.
Very good.